Today we have Lauren, and we've worked with Lauren a few times before. What we're going to focus on today is the right hip flexor, which acts up when she's running. And so some approaches to this kind of an issue would be to really focus on the psoas, the iliacus, the tensor fasciae lata, the rectus femoris, the main hip flexors. Look for trigger points, adhesions, or maybe some inhibition or weakness or disengagement of the muscle, and that's totally valid. My approach is more to look at the whole lower body, of course, and look for patterns where, for example, like poor knee mechanics can lead to compensation in the hip, or poor dorsiflexion of the ankle can lead to compensation in the hip. Sometimes misalignment or tendencies of vertebrae to adopt unhelpful positions in the lumbar spine, creating unequal weight bearing, and that can lead to asymmetrical stress in the lower back and this kind of an issue. This has been going on for a long time, yeah, and so it's not the kind of thing that we would anticipate correcting in one visit, but goal would be to get some insight and some relief, and see if you can't move it in the right direction. So my first few minutes here, just palpating, getting her used to my touch and me getting a sense of what's going on in her spine, and definitely keying into this upper lumbar segment. Feels like L2, which feels like it's tending to shift to the right, which is what made me think before as I was talking about asymmetrical weight bearing. So yeah, it's kind of stuck. And so when a vertebra shifts one direction or the other, and it doesn't even need to be stuck in that direction, it can just sort of have a tendency to shift in one direction, it's going to create unequal weight bearing on the SI joints, which is then going to create a need for some compensation and adaptation. And so a big part of what we're always doing with body work, in addition to relieving pain and trying to identify these biomechanical asymmetries and alterations, is to improve the resiliency and adaptability of the system as a whole, so that when you get these asymmetries or these inefficient biomechanical tendencies, they don't have as much of an impact on the whole system, because you're increasing the resiliency and adaptability of the whole system. So now feeling down the right hip, and I definitely feel this tendency for the hip to rotate this way. And I kind of been here before on this calf, and yeah, sensing that some stuckness in this distal ankle is present and creating a need for that internal rotation preference of the tissues around the hip. Does that make sense? Yeah. So I'm going to start today. We're going to work your whole right leg, but I want to start on the foot and ankle. Okay? So I love to see nice, that's really good dorsiflexion. That is really nice. What I'm more keen in on is some resistance to eversion. That's this movement. So inversion is always going to be more than eversion, but yours is a lot more. And there's this restriction here around your lateral malleolus. So we're going to do some gentle induction of eversion and mobilization of the fibula while we do that. Good. Getting a little space between here, the Achilles tendon and the peroneus longus. Good. There's that fascial line of the tibialis anterior that comes down the lateral tibia and crosses over the ankle in front to insert right about here. And it's a lot of times is tight and restricted when we see this pattern of restricted eversion of the ankle. Pressure okay? Good. Okay. Good. We're going to work the glute now and piriformis. So I've got the outline of your sacrum here. So sacrum, there's the gluteal muscle right there. So our SI joint, your SI joint is right here. This whole line here of about 3 inches. It's a big joint. So that's where we get a lot of the resistance to hip rotation is in that joint. So let's induce a little movement. So I can see here and feel that her hip is moving a little more freely and a little stuck piece of gluteal muscle and fascia right here. And it's so interesting the way this gluteal fascia comes up, crosses the sacrum, and blends with the thoracolumbar fascia on the opposite side. And so we get that this way, and then there's this X, a really dense fascia that crosses right at the lumbosacral junction, gives us a lot of stability. But on the other hand, if it's tight, it can give us a lot of restriction. Yeah, that little X is usually pretty tender. Okay, feeling a trigger point right here in the piriformis. So we're just going to hold that for a moment. Good. Okay, so now as I come over this big knob on your hip called the trochanter, I'm getting more into that hip flexor. So you can kind of get a sense of the continuity of that tissue. We like to divide the muscles into hip flexors, extensors, abductors, groin, but it's really very much continuous. Like sleeve of muscle around the whole thigh. This is my preferred way to get into the iliacus and psoas, is this way. So come right off the iliac crest and mindful that there's 3 layers of abdominal muscle in there and lots of organs. And so not to just go straight in, but kind of like curve around on the bone and come in behind the organs and just kind of gently sweep over that superior third or so of the iliacus that you can reach pretty easily, just like this. My hand in the back is just providing some gentle support. Good. Can you take your top arm and bring it up over your head? That gives us just a little more space right here, and take a nice deep breath. We're going to bring this leg into neutral. Just kind of let the knee relax. Good. I'm getting a little bit more length here through the flexor. Yeah. Good. We can see we're just inducing a 1/4 inch of movement of that external rotation of the hip. That's good. So now we can reach the bottom half of the iliacus and the psoas here. So I got the inguinal ligament running right about here where my pointer finger is. And of course they run right under that ligament, pretty deep, and insert onto the front of the thigh. So I'm not a fan of digging in this area. First of all, it's really sensitive. The skin is very sensitive. It doesn't really like to be pulled. And also there's the femoral nerve, artery, and vein right in there that I don't want to be digging and grinding my fingertips into. So this is really just more of getting a deep fascial release without a lot of deep pressure means you have to kind of finesse it and know where the fascial planes are so you can hook onto them, for example, right here, and give them a stretch. So I've got her tensor fasciae lata right here, her rectus femoris right here. I'm distal to the psoas insertion, which is about at this level. But what I can do is grab onto that fascial plane, give a little pressure to hook onto it, and give it a bit of a distal pull. And in that way, get a deep fascial stretch coming all the way up into the deep hip without having to endanger the delicate tissues in there or put the patient through a lot of discomfort in order to get it moving. There are some people who really like that deep, direct pressure, and I can do that too, but for the most part, especially when it comes around the groin, I want to be as gentle as I can.